talking, sir. You have to already get and mathematics. I'll be giving a talk on sports medicine. Most common injuries you see sports medicine are maybe around the knee and the shoulder, so I'll be focusing on that. Firstly, to start with knee injuries, the most common injuries are isolated meniscal injury, protracted medial or lateral. The ACL plus minus meniscus, any of the meniscus injury, which is the most common form of injury you see. Ligament distribution pertaining to MPFL tear, isolated PCL tear, and multi-leg injuries are very rare. Injuries on the shoulder can be divided into two groups. One occurring in the younger age group, less than 40, and the others in the older age group, more than 40. In the younger age group, we see ligament distribution patella most commonly. Ligament distribution shoulder to pancreas lesion, slap tear, and rotator cuff tear. In the older age group, the most common form of injury is the rotator cuff tear, impingement syndrome, and adverse capsulitis. This is more commonly known as frozen shoulder. This is the basic anatomy where knee joint is basically a short concave form of joint form of femur, tibia, and patella. So the ligamentous structures around the knee are the most important restraints for maintaining the knee joint. This is the current picture of the knee joint. Here you can see the ACL. The anterior cruciate ligament has been marked. The medial meniscus on the medial side and the lateral meniscus on the lateral side. This is the top view of the tibia. Seen from above, the two bundles of the ACL are being marked as an AM bundle and posterolateral bundle. The lateral meniscus is small semicircular C shape, and the medial meniscus is the larger concave shape. This is the attachment of the ACL on the femoral condyle. Today in the live surgery, we saw the femoral condyle was exactly in this area where the PM bundle are marked. The tendon was exactly in the center of the footprint of the ACL. The lower area shows the alignment of the ACL in the extension and the flexion. In extension, both the bundles of the ACL are parallel to each other, and in extension they cross each other. In flexion they cross each other. How do we approach these injuries? Most of these injuries are approached arthroscopically. This today, as we saw, this is the normal appearance of the meniscus. The picture on the left is the medial meniscus. The picture on the right is the lateral meniscus. You can see the lateral meniscus is a bit above the tibial condyle because it is more lax or less bone to the joint. These are pictures of meniscal injuries. With the probe inside the meniscal tear. The second picture is of a radial tear of the lateral meniscus. The third picture now is a bucket-handed fragment which is placed in the notch, which we remove surgically. These are post-meniscectomy pictures where the bone part is straight and the meniscus is stable, balanced peripheral. These are images of meniscal repair, where meniscal repair is possible only in case of very peripheral meniscal tears at the meniscocapsular junction. This is an image of a tone. So we saw the ACL was off the lateral femoral condyle, and we were able to restore it post surgery on the condyle. The lower picture is of the graft. This is graft. This is the these are few other images of the ACL. On the picture on the left, they are prone ACL. On the right are the images of the reconstructed ACL, along with the PCL at the top. This is an external image of the surgery. The second image is of the tension hamstring graft. Usually we tension this graft because this graft tend to become loose later on. So we pre-tension and then put it inside. These are the implants which are used during the surgery. We have evolved from previous institutions. Now we usually use bio screws, which could be made of HA and KVLA. The images on the right are of titanium screws. The upper implants are used for tibial fixation. The lower implants are used for femoral fixation. The one we use today was a tight button from Arthrex, where there is a dynamic tube which we can pull through later on to reduce the size of the graft. This is an image of the reconstructed PCL. Here the graft is squared in a V-shaped manner, and the tunnels are in the medial condyle of the femur and the graft is inserted. This is an MR image of a tear, medial square, and that is carried picture of the MPFL ligament. This is a picture image of MPFL reconstruction, where they use the glasses to reproduce the medial perpendicular ligament or reconstruct the medial perpendicular ligament. The image on the right, you can see the white structure that is the reconstructed tendon the MPFL. These are the trunks used for MPFL reconstruction. The one on the left are the anchors, and a small wire spool can be seen on the right. Today also we had the patient had a small osteochondral defect in the medial femoral condyle. Such defects are usually addressed by microfracture, wherein we put some drill holes in the condyle so that the blood comes out and we heals by fibroparticles. Larger defects require mosaic where special equipment is required to harvest the cartilage and bone graft from non-articulating areas in each joint, beside the trochlea, and then we punch in those grafts in the cartilage defects. These are the instruments required for harvesting the graft, the bone punches. Now we come to the shoulder joint. In older age, the most common form of injury we see is the rotator tear. On the left, there is a picture image of the rotator tear. On the right, this is the MR image. The whitish portion between the tendon is the part of the tendon. These are the anchors we use for shoulder rotator repair. These are bioabsorbable or titanium. Depending upon the bone quality, we use anchors. If the bone quality is weak, then we use metallic anchors. And along with the anchors, see the lower image, the threads are coming out. The anchors go into the tendon using those threads. This is an arthroscopic image of a rotator supraspinatus tear. The white structure you are seeing is a biceps tendon. This is the U-shaped tear of the supraspinatus, which has been repaired successfully. This is a lateral focal image. Lastly, we see what happens in a recurrent dislocation of shoulder. The anterior inferior ring of the labrum closed tears off, which is known as a Vander's lesion, which is restored after surgery. This is the image where the glenoid is at the floor, the humerus is at the top. The labrum is lying free away from the glenoid. Post surgery, it comes back and restored the glenoid. Thank you. Dr. Manpreet will give a talk on rehab for our sports injury patients.
Thank you, sir, for your knowledgeable lecture on sports and medicine. Here also we need the knowledge of rehabilitation. And for this, I again request Dr. Manpreet to deliver her thoughts.
Good afternoon once again, everybody. So, athletes participating in contact sports, especially basketball, football, are more prone for ACL injuries. Now, the key to successful treatment is the accurate and early rehabilitation. Goals of ACL rehab are to restore the normal range of motion, because it's very important for the athletes or sports persons to go back to the field as early as possible. Reducing inflammation and pain, regaining normal strength, and to return back so that they can return back to the pre-injury performance levels. Now, we have divided the rehabilitation plan of our sports persons into different phases. So, phase 1, especially of 1 to 2 weeks, phase 2, that is 2 to 6 weeks, phase 3, 6 weeks to 3 months, and the phase 4, where the athlete is preparing to return back to field, that is 3 to 6 months. And after that, the phase 5, that is the last phase, then we can go back to sports field. Now, the first week, that exercises which I have discussed in the total knee replacement or THR patients and the movements invalidation. Now, the difference is long knee brace, which I also mentioned. We give to our this ACL patients, ACL reconstruction patients for at least 1 to 3 weeks, so that the structures of the graft that should be supported and the healing of the graft should occur, and medial laxity, there are chances of that, so we want to avoid that. That's what we give for the first 3 weeks, long knee brace for our sports persons. Full weight walking with the stick, the patient starts walking the next day after the surgery. No SLR, that is the reason behind we just avoid straight leg raises in sports persons for at least 6 weeks. Because again, straight leg raises, I mentioned the open kinetic chain In early rehabilitation plan of the ACL patients, closed kinetic chain exercises are the first to start with. Then we will proceed to the open kinetic chain exercises. Because if you start with open kinetic chain exercises, the early rehab that can lead to anterior laxity. So just want to go step by step. That's why no SLR for first. Then is knee bending 0 to 40 degree. That is also in the first week of the ACL patient. Starting quadriceps and hamstrings. Then week 2, brace to be continued, knee bending to be increased up to 90 degrees, full weight bearing walking and exercises in the other first week will be continued, which I told you. Now the week 3, there is a bigger ankle inflection now up to 110 degrees. That is exercises as before. Now we will start the long knee brace. We will start with the hinge knee brace. Now in this hinge knee brace, some knee bending is allowed. That is up to 90 degree and but still support is necessary and we give hinge knee brace. BMO exercises, cryotherapy is going side by side. Now we keep this while walking the patient, but he doesn't need any assistive aid. Open chain exercises to start with, mini squats, BMO setting rest exercises as before. Now the role of standing exercises, prone knee bending, cycling, and strengthening of quadriceps and hamstrings. Hinge knee brace to be worn only while walking now. Otherwise, with patient now straight leg brace also to be started because 6 weeks started. Single leg stands to increase the balance or improve the balance and proprioception in the patient. And hip adductor strengthening exercises are also to be included. Either you can start with the therabands because in therabands we all know we have different color coding for the resistance. Red, green, blue. So we have different resistance accordingly to therabands. Now the week 5 to 6, our athlete is going for the exercises strengthening program and 6 weeks to 3 months. Now the strengthening exercises will be more vigorous with greater amount of repetitions, resistance will be increased. Then leg press, gym training will be started. Now the sports person is not wearing any brace. He is doing all the activities without any supportive brace. After that, leg will be started. Skipping, depending upon the patient is having good muscle tone or not. Agility drills running forward, sideways, backwards. So progression of activities will be there. Now figure of age line between 6 to 9 months. So sports specific training, this is the last phase which I discussed slide, the phase 5. Now the patient will go back to sports specific training. Now this is actually the recent researches, what they say, the current ACL rehabilitation approach. Knee flexion gains should be immediate and low kinetic chain exercises should be started with early functional activities and earlier return to sports. This is the current ACL rehabilitation approach. Again, the same concept, every individual will vary, so the recovery will vary accordingly. But return to play should be individualized rather than a rigid form because it will vary, so it depends. The same thing, the lesion, inflection gains and extension, terminal knee extension, already mentioned. Last, very important point, a multidisciplinary team approach of sports physiotherapists and sports medicine surgeon. Because it's only sports medicine surgeon will tell, sometimes weight restriction is there. Either suppose ACL reconstruction is being done, but meniscal repair is also there. So there are some weight restrictions and the rehabilitation plan will completely differ from that. So that is the role of the sports surgeon, which is helpful for the sports physio to plan the protocol accordingly. Thank you so much.
Now, being a physiotherapist, I really feel that physiotherapy is the most important aspect in all the post-operative cases. Thank you, Dr. Manvi, for sharing your advanced protocol with us. Now, I'd like to invite the state for the vote of names.
Before I start with a lot of things, first we would have to love to have quick words from our chief guest and guest of honor. Okay? What they would like to share with the audience out there. Dr. Natish, if we start with you.
Good evening, everyone. It's a pleasure to now attending Focus Group Physiotherapy. And today I'm seeing a lot of physios come from and good job in the interior. So once again, if you want to live this world, we have to not to be static. What we say is true. I was listening last 2 days back, the living legends in India. This one of the lady, everybody is going the CEO. She said, three lessons from my life. One is always be a student and curious to learn something. The second, be a passion about your work, not as a job. The third, so try to other people come out. Here I am seeing a person living in front of us is Dr. Manoj Wadhwa. Give a round of applause. One he's learned everything. I'm seeing him last 7 years. He's still same. Even he doesn't have any gray hairs. But and his approach has totally changed. 2 years back, what listen, now I'm listening is totally changed. So please, for physio, if you want to live here in this world, in this technology world, the statically it's not possible. And second one is, everybody is on Nokia, once upon a time one of the topmost mobile in the world. Now not in the market. Only one because of they are not updated at the time, not follow the people demand. So please learn things for a customer, not for what you have. So if what they deficit, that's important. The customer say want to flex in 90, that's why start with 90 deflection. So please physio. So go to the patients what you need of demand. Well, like example, last month I went to learn of NLP, it's neurolinguistic program. So every physio, so you're learning psychology also. So what patient come to you for a short mentally. So who is going to do so? Mostly. It's a part you have to come multiple direction, come outside, and you have to feed the people in a different direction, mental, physical, and spiritually. So learn every day. It is every day is a new day. And give a round of applause to Dr. Manoj Wadhwa, giving the opportunity to stand here. Thank you.
So Rakesh, you made my evening. I'm delighted for the kind work. May I request Dr. Michael Rush to come? So please share everyone. To the director, Dr. Manoj Wadhwa, the guest of honor, Dr. Nargis Aurangzeb, the chairperson, Dr. Ajay Prasad Gautam, and all the orthopedic surgeons of this hospital, the delegates, and my dear students, many of them in these hospitals, and all the physiotherapists. So first of all, I'm honored to be in this scientific session for today, and I think after long years, I can tell that Dr. Manoj has given a premium platform for the physiotherapists on today to share on this joint technology conference. Okay, so a lot of physiotherapists are here, but I'd like to say one word today. The orthopedic surgeon succeeds on the day he does the surgery, but the physiotherapist succeeds until he does the complete rehabilitation. So where comes the integrated approach? So let us all follow the same rehabilitation shared by Dr. Manpreet and Dr. Manoj Wadhwa sir. His wonderful, amazing conference today. He's sharing knowledge on the TPR and THR. Let us all follow the same rehabilitation. And one other thing I like to tell is, I am very confident today anybody to refer for the orthopedic surgery with Dr. Manoj Wadhwa, and let us all follow that and succeed in our integrated approach. Give a round of applause for Dr. Manoj Wadhwa. Thank you so much. Friends, last but not least, may I request Dr. Ajit to come here and to share his thoughts with all of us. We have esteemed faculty today with us, and actually, we would be delighted to have their inputs.
Very good evening all. And I think so on the behalf of all gathering, I would like to say thanks to Dr. Wadhwa for such a educating and enthusiastic and enlightening experience for all of us. Okay, it was a pleasure for me and all of our physios which have come over here to such a learning and a better experience for all of us. Okay, so from my side and from all of the physios here, I would like to congratulate you for your future and future endeavors. Thank you.
So it has been a very pleasant Saturday for us, very pleasant, and from the core of our heart, we are getting really entertained. We had troubles in our city calls, and let me now share up. And before I end, let me compliment the team which was working at the back block at all. It's not me, frankly, I'm just a face. And the lady asked gave us a big round of applause for Abhijit, Dr. Majmoor, Dr. Sruti, Dr. Mantri, Dr. Sanjay, Rajni, Sapna, and everybody from the team who has been working on everything. I shared with the chairperson in the morning, I'm going to share it with you why we had a trouble across. We conceptualized this idea. Then I knew what this area can accommodate. So when those came across to me and asked me, sir, could I say, no. This was my first open forum with a physiotherapist, and I have always been running forums with on the scientific, the doctors, and the parameters, and my rule is 30% attendance. So I told him, if you want to call 100, you can invite to 300. And now you have is 287. I'm wrong. It goes on, but big round of applause for us. Please give me all this time. So, again, as you learn, you have taught me you are far more inquisitive, aggressive, curious to learn than majority of others. Believe me, I always believe in one thing. He is really marvelous. The aggression should never die out. And oh, with the thought process, my surgeons would kill me for saying this word, but today physiotherapists are far more keen to learn than the surgeons. Hats off to those people. So everything we have to relate it should move on and on, but we have to travel long distances. So on behalf of the team actually, I really thank and congratulate one of you who is here with us this evening. We have MP outside the ring for all of you. And there are also certificates with all university credit across, which is there a second counter? There is a second counter. And thank you all for making it happen. Thank you, chairpersons, thank you, delegates, thank you, organizers. And let's make it as a regular yearly event. That's what is the kind of message. Thank you so much.
ये देखो इसको ये ऊपर आ गया था ये नेक्स्ट इसको कैसे लेंगे
आपकी ऑलरेडी जा चुके सब देख रहे हैं लाइक क्रिकेट मैच
ये वहाँ पे तो